I'm going to paraphrase Shakespeare. To give or not give Coumadin, that is the question. Patients with atrial fibrillation who are at risk for bleeding are a real problem for clinicians trying to answer this question. One of my teachers used to say the answer depended on whether his last patient either bled or had a thromboembolic event. One of the problems is that known risk factors for bleeding during anticoagulation treatment are largely the same as those predicting thromboembolic events in patients with AF. Now in circulation, researchers investigate how to maximize the likelihood of avoiding both stroke and bleeding. They used more than 182,000 subjects with AF in the Swedish hospital discharge register and studied them for an average of 1.5 years. The primary endpoint was net benefit, defined as number of avoided ischemic strokes with anticoagulation minus the number of excess intracranial bleedings, with a weight of 1.5 to compensate for the generally more severe outcome with intracranial bleeding. You may or may not be surprised at the outcome. They found that the adjusted net clinical benefit favored anticoagulation for almost all AF patients. The exceptions were patients at very low risk of ischemic stroke with a CHADS 2 VASC score of 0 and moderately elevated bleeding risk. So, when you struggle with whether to anticoagulate or not, it seems that in almost all patients with AF, the risk of ischemic stroke without anticoagulant treatment is higher than the risk of intracranial bleeding with anticoagulant treatment. The net benefit: more patients benefit from anticoagulant treatment. I'm Peter Block, and this is a CardioSource Heart Minute.